Welcome to the second part of this series of presentations on the microorganism Helicobacter pylori and the diseases that it causes. And the second part here, we're going to look at 4 slides dealing with the clinical diseases that are caused by Helicobacter pylori. And so we will talk about duodenal ulcers, peptic ulcers, and then gastric adenocarcinoma, and finally malt B-cell lymphoma. So those are the 4 diseases we'll look at. So let's get started. And so the first thing, let's address duodenal ulcers. So this is the left image here. And so these are usually associated with Helicobacter pylori infections. And these ulcers occur in the first 1 to 2 inches, so that's 4 to 5 centimeters, of the duodenum that is proximal to the pyloric sphincter. So if I just turn on a pen here, I can show you what we're looking at. Okay, so this endoscope has been snaked down through the cardiac sphincter at the top, through the cardiac antrum into the pyloric antrum, and down here at the end, this is the duodenum. And so it's the first 1 to 2 inches of the duodenum there where these ulcers occur. These are traditionally treated with antacids such as Tagamet and Zantac, but the cessation of treatment results in ulcer recurrence. If you eliminate Helicobacter pylori using antibiotic therapy, that completely cures the ulcer and is effective in approximately 80% of individuals. Once you get over 50, the success rate drops significantly. Once the bacteria is eliminated, the patient can stop taking antacids. The antacids are primarily for symptom relief. So the lesion, the ulcer we're looking at here, and I'll just trace around it. The lesion we're looking at here is approximately 2 centimeters in diameter. So that's the ulcer there, about 2 centimeters in diameter. The blackness that you see in the center of the ulcer is associated with bleeding, and so that bleeding can become pretty serious. The bleeding can persist, and if the bleeding can't be controlled, then blood transfusions can be necessary. The way that bleeding into the GI tract is often diagnosed is very, very dark streaks of blood in the stool, and so that's pretty serious. So this is being viewed through the pylorus, and so we're looking down the duodenum towards the small intestine, and so that's a 2 centimeter ulcer. That's a duodenal ulcer. Okay, the second one there, peptic ulcers. This is a relatively deep ulcer that we're seeing here, and I will just trace around it again so you know exactly what we're looking at. That's the ulcer there. No blackness, so this ulcer is not bleeding, or hasn't been bleeding. And this is just above the pylorus in the stomach. So we're actually down at the bottom here. This is actually the pyloric sphincter, and so on the little diagram, the stomach over to the right, that's the pyloric sphincter right there, and so we're just above the pyloric sphincter in the stomach. If this perforates the stomach, then things can get pretty serious, and we can end up with bacteremia and septicemia. Now, only about 70% of peptic ulcers are caused by pylori infections. The remainder are probably caused by things like the corrosive effects of aspirin and aspirin-like medications. These respond well to antibiotic treatment if pylori is the causative agent, and about 70 to 90% of patients completely recover if the pathogen can be eliminated. Now, at the bottom of the page here, you obviously can't click on this, but this is a link which I will post in Canvas underneath the videos that I put in the videos page, and that will take you to a little interactive flash animation where you can look at some of these diseases. You can look at the ulcers and the adenocarcinoma and the malt lymphoma, and so I will post that. Just make sure you do review that, because that is fair game for your quiz. Okay, let's move on and take a look at our next disease. This is gastric adenocarcinoma. Carcinomas, which you've probably heard this word before. Carcinomas are cancer of epithelial cells, and these are the cells that line the interior of organs and organ structures. And so adenocarcinoma is a related cancer that is a cancer of the epithelia, which has glandular properties. So that's a secretory tissue cancer. So that's an adenocarcinoma. So the presence of pylori in the stomach confers an approximately about six-fold increase in the incidence of these types of gastric cancer, and that's about half of all the cases of gastric cancer which are seen clinically. Chronic gastritis, so chronic inflammation of the stomach epithelia, is a significant risk factor for gastric adenocarcinoma. And this is usually found in the pyloric antrum. And so remember, the pyloric antrum is this chamber down kind of in this region of the stomach versus the cardiac antrum, or the fundus, which is up here at the top. So these usually form down here in the cardiac antrum. And so that's consistent with the site of colonization of Helicobacter pylori. And so a little bit of a low resolution image here, but you can see a diagram of an ulcerating lesion, and these can become very serious, and again they can bleed. And at the top here you can see in the endoscopic image up here, which has been taken by an endoscope. And so an endoscope is one of those scopes which is going to come down from the upper digestive tract into the stomach, and terminates in a camera which is used then to visualize the part of the stomach that the clinician is interested in. And you can see that up here in part A of this figure, that's a particularly nasty ulcerating, bleeding adenocarcinoma, pretty serious and probably extremely uncomfortable. Okay, so let's look at some of the factors for in Helicobacter pylori that cause gastric adenocarcinomas. And so this is a pretty busy slide, and so I'm just going to point out some main things that go on here to drive tumorigenesis. And so I'm going to start over here on the left. Let me get this pen going. And so I'm going to start over here on the left, thinking about chronic inflammation. And so one of the things that Helicobacter pylori will do when it infects is it will trigger an inflammatory response. That means that immune cells are going to move into the region of the infection, and there's going to be a lot of reactive oxygen and reactive nitrogen species that are produced by the phagocytes that move into the site of infection. And the ultimate cause of those can be inflammation, and part of inflammation is a lot of cell division. When cells are killed in tissue by the inflammatory response, they have to be repaired, they have to be replaced, and that repair and replacement of cells involves a lot of DNA replication, and so we can see an increase in mutations, basically. That's what this box here is saying. And then those mutations can obviously occur in tumor suppressor genes, the genes that stop tumorigenesis, and they can also occur in proto-oncogenes, which become oncogenes, and that can then drive carcinogenesis and proliferation. So that's the chronic inflammation piece. Don't worry about all this stuff over here. We're going to ignore that. That's looking more at metastasis and local invasion of the tumor. In terms of these virulence factors, CAG-A, VAC-A, and then obviously endotoxin LPS is a gram-negative species, so we've got endotoxin in play. There is some complicated genetic pathways which can basically be perturbed and lead to more aggressive tumorigenesis because of a loss of cell morphology and cell function. That's right down at the bottom here. But don't worry at all about any of these genes in any of these boxes here, or any of the mechanisms. All you need to know is that there are these virulence factors here, and they are probably in some ways carcinogenic. So what I do want you to think about is the role that chronic inflammation plays in driving tumorigenesis. And so you might want to do a little extra reading on that, that's fine. But expect questions on your quiz about how chronic inflammation can drive tumorigenesis. Okay, so that is gastric adenocarcinoma. The last thing that we should probably talk about here is B-cell lymphoma, and I'm not going to labor this too much. As you can see, all I've got here is a link to that website again. So at this point, you should probably reference that website. So just to tell you what B-cell lymphoma is very quickly. MALT stands for a mucosal associated lymphoid tissue. That's MALT, and this kind of lymphoid tissue can undergo malignant transformation to produce lymphomas. And so you probably heard about leukemias and lymphomas. And leukemias are bloodborne cancer, as are lymphomas, which are actually tumors of the lymphatic system. And leukemias are single cell cancers. And you see how you get a hyperproliferation of certain types of white blood cells. And this leads to leukemias, whereas lymphoma is again a proliferation of white blood cells, but these form masses, and they're often found in lymphatic tissue. So that's what lymphomas are. There are some interesting, important differences between leukemias and lymphomas. In 90% of the cases where you see B-cell lymphoma, it's associated with pylori infection, so that's a very close correlation. The malignant changes that occur in the tissue can lead to low-grade lymphomas, but if you actually eliminate the bacteria, then chemotherapeutic intervention, which eliminates the bacterium, that's antibiotic therapy basically, can actually reverse the carcinogenic process, and that's not uncommon in tissues which are driven to tumorigenesis by an inflammatory response. And there are actually schools of thought which suggest that you should probably take half a children's aspirin to lower your inflammation and lower your cancer risk. I'm not necessarily suggesting that you go ahead and do that, but there are schools of thought which indicate that that may be a good thing. Okay, so that gives us 4 diseases that you should think about: duodenal ulcers, the peptic ulcers, the gastric adenocarcinoma, and the B-cell lymphoma. And so the thing we'll look at next is diagnosis of pylori infection.